I'm Jerry Walensky. I'm from the McGovern Medical School at UT Health in Houston, Texas, where I'm an emeritus professor of neurology. The presentation made by Gilles Adam on prognostic factors was a very nice consolidation of data that's been primarily developed here in France in looking at the differences between relapsing and progressive phase disease. Over the years, it's been a very useful data set. We clearly have identified age as a very important factor in terms of understanding when these transitions begin to occur. We understand that once people do enter the progressive phase, relapses become increasingly less evident and probably less important in terms of what's contributing to accumulating neurologic disease. And the one thing that's really confounding our prognostic factors, both in terms of age, gender, perhaps even what EDSS level one enters the phase of the disease, is the impact of our treatments. They've been very consistent over the last few years for relapsing disease, if you will, improving all of the time. And now we're just beginning to get consistent therapies that are likely to be approved and used more consistently in progressive phase disease. And it's going to be very difficult to disentangle the effect of those drugs from what was a natural history that we depend on, but may no longer be what we're going to anticipate. I think Fred Levelin made a very nice summary in his overall presentation about those drugs, particularly for primary progressive disease. The trials which failed but gave us a lot of things to learn from in improving and consistently refining trial design, to the point where we've now recently been able to show an effect of an anti-B cell drug that is consistently affecting not just clinical outcomes but MRI pathology. And so I think now we've put a major crack in the wall for the progressive disease state as it presents in this unusual form of the disease, that is primary progressive, where progression characterizes the disease from onset without attacks. What's a little bit more difficult, but it actually, in my mind, will come out to be the same thing, is what we call secondary progressive disease. And we've had a difficult time cracking that nut too. But I think as we see now some drugs that are beginning to show an effect, I guess siponimod is the first of those that may come through the regulatory pathway. It makes me feel that if we control inflammation early and late, then we're going to be able to see that we can slow progression. And above and beyond that, we're getting some hints from other drugs, which as best we know are not even anti-inflammatory, that they may be able to interdict some of the secondary changes that are occurring and that may be driving the progression even in the absence of obvious inflammation. So we're looking forward to the large definitive trials of high-dose biotin and other drugs that are being more aggressively looked at. It may be harder in secondary than even primary because we get to those patients later in the overall duration of the disease. And we know in every phase of the disease where we have drugs that work, they do work better the earlier we start them.